Hello everyone, welcome to this lecture, Analytical Epidemiology. Aim is to test the hypothesis. We already studied descriptive epidemiology. The aim was to form the hypothesis. Now we are going to test the hypothesis. In under analytical study, we are going to study in detail about case control study and cohort study. Here, direction of inquiry is this way and the time goes this way. So we'll be selecting the population first and then we are going to take case and controls out of it. Cases, those who are having the disease. Controls without the disease. Cases can be exposed to a risk factor or not exposed to a risk factor. Control can be exposed to a risk factor or not exposed to a risk factor. Now features of the cohort study. In cohort study, disease has occurred before the start of the study. From the outcome to exposure. Exposure, what are the risk factors cause that disease we are going to check. That is why other name for this case control study is backward looking study. Now comparison group is there in the study, that is controls, to support and to refute an inference. Now the steps, first we are going to select the case. Who has the disease? Disease people can be taken from the hospital or general population. If we are taking from the hospital, one hospital might be having the similar characteristics in the case, so better to take from different hospitals. And then tertiary care hospital may be having the severe cases, so better to avoid from tertiary hospitals. And comes selection of controls, so those who are not having the disease. If we are taking cases from the hospital, we can take controls also from the hospital. This can be of different disease, or control can be in general population without any disease. It should be of same geographical area. Can be neighborhood also. For one case, there should be minimum of one control or up to 4 controls. For one, there are two type of controls. Multiple control of same type means for one case we are going to take one control or two controls, three control, or up to 4 control we are going to take. In multiple control of different type, suppose one group is having 30 cases, we are going to take one group with 30 people. We can also take a different group 30 with, we can compare with this group also and this group also. Now matching. Matching is a procedure of selection of control for cases. Individual matching is there. For one case, we'll be selecting one control. For group matching, we'll be making the strata according to the similar characteristics. So suppose this is of 1 to 5 year group, this is of 6 to 9 year group, and 10 to 12 year group. Like that strata we will be taking for cases, and again same for controls. Now take 3 from the case, 3 from control, again 3 from this case, 3 from here. So this is how group matching. What is overmatching? Sometimes if we match according to the age, in the above case we matched according to the age. So if we are matching with the particular factor, we can't study the influence of that factor in the study. So if we match multiple factors like age, gender, occupation, economic status, and rural urban area, whatever factors we have matched, we cannot study how that factors are influencing our study. Now measurements of exposure based on interviews or questionnaire, past records or medical examination, environmental surrounding, we are going to ask about the exposure of risk factors. For example, we are having cases of lung cancers. So during the measurements of exposure, we will be asking about the smoking history, occupational exposure, radiation exposure. Now analysis. Based on the answers to above questions, we are going to make the cases and controls into two groups. So cases can be exposed, non-exposed. Controls can be exposed, non-exposed. A, B, C and D. So the total exposed is A plus B. Total non-exposed is C plus D. Total cases are A plus C. Total controls are B plus D. Now, the first exposure rate among the cases. So we know cases are A plus C. So exposure is A. So A by A plus C. Now exposure rate among the controls. We know controls are B plus D. So exposed is B. So B by B plus D. Third one is odds ratio. Odds ratio is equal to odds of exposure among cases and odds of exposure among controls. Now odds of exposure among cases are among case exposed is A. So non-exposed is C. So A by C. Odds of exposure among control exposed controls are B divided by non-exposed control are D. We get A by C divided by B by D. So how we can write this? A by C, this D will go up and B will come down. So the formula for odds ratio is AD upon BC. So if odds ratio is more than 1, exposure is a risk factor. Equal 1, exposure is not a risk factor. Odds ratio is less than 1, exposure is a protective factor. So interpretation, smokers have 8 times higher odds of developing lung cancer compared to non-smoker. Now advantage of case control study is easy, inexpensive, rapid to perform. We can study several risk factors. From the case of lung cancer, we are going to ask the multiple exposure history, good for rare diseases. No ethical issues, not going to do follow-up or intervention or anything. We can calculate strength of association between exposure and outcome. Now disadvantages of cross-sectional study, we may get bias. It can be selection bias while selection of the patients, Bergson bias. If we take hospitalized patient, there can be bias. Memory or recall bias, we are going to ask about the whole history of exposure. They may forget about some of the exposures. This temporality is not achieved. Risk factor should precede the disease. Matching is as a difficult task. Examples for cross-sectional study, we are going to study with whoever has congenital malformation or thromboembolism and CA vagina. Then we are going to ask about the risk factors of thalidomide use or OCP exposure or age, radiation, smoking history, OCP use is there or not. Now cohort study, forward looking study. First we are going to select the population, from that who is exposed and who is non-exposed, and then exposed can have the disease, cannot have the disease. Non-exposed group can have the disease, cannot have the disease. Time and inquiry direction is of same. This study starts before the occurrence of disease. We are going to start from the exposure to outcome. Comparison group is there to support or refute an inference. There are 3 types of cohort study: prospective study, retrospective study, and ambidirectional studies. Prospective, suppose we are at 2026 right now. Start of study is 2026. 2030 we are going to check for the outcome of the study. In retrospective cohort study, we are now at 2026. So at 2020, whatever exposure happened, we are going to ask the patients, and then based on the record we will be tracking those patients around 2024. Any disease happened to them, we are going to check. That is retrospective cohort study. The outcome, exposure, everything happened before the onset of the study. Most of the time this is record based. Ambidirectional studies, so now we are in 2026, started in 2020. The outcome we are going to measure in 2030. So this is ambidirectional. Other name for retrospective cohort study is historical cohort study, prospective study in retrospect, non-concurrent prospective study. Now the steps in the cohort study. First one, selection of study subject. Study subject can be general population or can be special group. Usually special group we use if the exposure is rare, whoever got the exposure. Next step is measurement of exposure. through interview, questionnaire or review of record or medical examination or environmental survey will be asking about the risk factors of that particular disease. From the study population, we are going to select the control group, non-exposed. Most of the time we'll be taking the comparison group of non-exposed from exposed group only. For example, this general population is smokers, so we are going to ask about the exposure now, about the how many cigarette you smoke, how long you are smoking, like that. And we are going to take out the comparison group, how degree of exposure we are going to make internal comparison. Smoking for less than 1 year, smoking for 1 to 10 year, smoking more than 10 year. More than 10 years we may be taking as a exposed group, and we will be comparing with the less than 1 year smokers. So this is internal comparison. If the degree of exposure is not there, we can take external comparison as well. So for that we can use general population from the same geographical area. Next one is follow up. We are going to measure the disease has occurred or not, lung cancer is there or not, like that. Now comes analysis. So based on the data we got, we are going to group people as A, B, C, D. A, those who exposed and having the disease. B, exposed not having the disease. And C, not exposed having the disease. D, not exposed not having the disease. Diseased total A plus C, not diseased total B plus D. So first formula is incidence rate among the exposed. A plus B is our exposed. In that incidence means those who have the disease, A. So A by A plus B into incidence rate, always multiplier is 1000. Now incidence rate among non-exposed. C plus D is non-exposed group. So those who are having disease in this group. C by C plus D into 1000. Now relative risk means incidence among exposed divided by incidence rate among non-exposed. Now attributable risk, incidence among exposed minus incidence among non-exposed divided by incidence among exposed. Population attributable risk, incidence among general population minus incidence among non-exposed. This non-exposed is there always. Try to remember, it won't change in both the formula. Incidence among general population minus incidence among non-exposed divided by incidence among general population. If the relative risk is 1, the exposure is a risk factor. If the relative risk is equal to 1, exposure is not a risk factor. If relative risk is less than 1, exposure is a protective factor. So the interpretation of relative risk, smokers have 8 times higher risk of developing lung cancer compared to non-smoker. Here we use risk of developing lung cancer. For case control study we use higher odds of developing lung cancer. Advantages of cohort study are good for common diseases. Study multiple diseases starting from the exposure. Later it can develop multiple diseases. For example, the exposure is hemolytic streptococci. It can cause rheumatic heart disease, it can cause tonsillitis, it can cause erysipelas, scarlet fever. Strength of association is established. There is a relationship between the exposure and outcome. Temporality established. At the beginning of the study, there were no disease. For sure that this disease happened after the exposure. Disadvantage, expensive, time consuming, ethical issues. We are going to do periodic follow-up, so there may be some ethical issues. Large population needed for this study. Bias, we have selection bias while selection of the participants. Information bias, there may be wrong information. Attrition bias, after some time they won't be willing for the follow. Example of this study is Framingham Heart Study conducted in US in 1948. There were 6,500 participants. Every 2 years serum cholesterol, blood sugar, BP, weight, and then cigarette smoking history they have checked for next 20 years to look for the cardiac problem. Famous smoking to lung cancer study was a cohort study. So here the start of the study is exposure, the end of the study is outcome, that is disease. The study group in case control is person with the disease. Here cohort studies exposed people. Comparison group, person without disease, here non-exposed. Outcome measures exposure rate among case, exposure rate among controls. In cohort, incidence rate among exposed, incidence rate among non-exposed. Measurement of risk, odds ratio used in case control study. Cohort study, relative risk, attributable risk, population attributable risk. Temporal relationship, exposure comes first and then outcome comes next. So it's not established in case control study. In cohort study, temporality established, but if it is a retrospective cohort, it is not established. Multiple association, we can study association between the exposure and outcome in all the studies. Now time required here is short, here is long. If it is a retrospective cohort study, time required is short. Study is cheap, here expensive. If it is retrospective cohort, it is cheap. Population size needed is small, here it is large. Potential bias, selection bias, Bayesian bias and recall bias. Here selection bias, information bias, attrition bias. Best when disease is rare, here best when exposure is rare. Problem, appropriate control, here problem, criteria and method changes over time. So we are at the end of the lecture. Hope you understood the lecture and thank you for listening.